Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be the facilitator for today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Be Well Texas providers, please make sure that you identify yourself during the session, or if you're joining via phone, please email your phone number and name to bewelltx@utisca.edu. EquiT, please share this email in the chat. Some housekeeping, please stay muted unless you are speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you prefer, you can use the chat feature. Please note that no predicted health information is allowed in either the chat or our discussions. Towards the end of the session, the Shout Texas Echo team will send out a link to the evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Additionally, this helps us get valuable feedback from you about how we can improve these sessions. Our didactic today is on reducing stigma and building trust with hospitalized patients, presented by Dr. Kristin Escamilla. Following that, we will discuss a case presented by Dr. Chen. We will start with introductions, followed by didactics, Be Well program announcements, case presentation, and open discussion. Thank you again for joining today's Echo. In the spirit of all teach, all learn, we encourage you to share your experiences, questions, and insight in today's conversation. With that, we'll do some introductions. Dr. Moriartis.
Hey everybody, Chris Moriartis from the Shout Texas team and from Dell Medical School, and I am a practicing hospitalist.
Thank you so much, Dr. Lindsay.
Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring here at Be Well, Texas. Thanks.
Thank you. Dr. Escamilla.
I am a community psychiatrist and I do clinical care at a crisis mental health unit.
Thank you so much for joining us. Dr. Chen.
Hi, my name is Ishal Chen. I'm a hospitalist at Baylor University Medical Center in Dallas, Texas.
Thank you so much for joining us. And Alana?
Hey there, everyone. I'm Alana Bolton. I am a program manager at Dell Medical School at the University of Texas at Austin and the director of Shout Texas. Thanks so much for being here today.
Thank you. And with that, we will get started with our didactics for today. Dr. Escamilla, whenever you're ready.
Great. Okay, I'm going to work on sharing my screen. So if you can be a little patient with me. Give me some. Okay, great. Let me get set up. All right. Hi, everybody. So as I said, I'm Kristin Escamilla. I'm a psychiatrist. I practice psychiatry at a crisis respite unit, which is sort of like an inpatient hospital, but just not as acute, over here in Travis County at our local mental health authority, which is called Integral Care. I've also been the psychiatry clerkship director for the past 7 years and have loved it. I really appreciate the opportunity to speak to you all about reducing stigma and building trust with hospitalized patients. This has definitely been a passion of mine ever since I decided to become a psychiatrist. All right, so just wanted to let y'all know that I don't have any sort of relevant financial relationships to disclose. And then I also wanted to let y'all know that we're going to be doing a little bit of interaction. Don't worry, it's all anonymous. If you can, just grab your phone, scan this QR code, or you can go online to slido.com and then put in this number. Make sure you do, I'm pretty sure you do have, no, I don't think you include that space, but usually the QR code is a lot easier. Whenever I advance slides to an interactive slide, you should take a look at your phone and that should update the screen for you to be able to interact, okay? Please let me know anytime if you have any questions. So as far as learning objectives go, these are the 3 things that I would like to cover. I will try to be very timely, but we're going to talk about stigma that's present in everyday clinical care, utilize various methods to decrease this and build trust with patients. And then we're going to spend a little bit of time trying to formulate our own actionable plans to decrease stigma and build trust in our environments. So in the chat, can you please tell us what role you play in patient care? I know we did do a little bit of introductions, but I was just curious to see exactly who the audience is and how you interact with patients. And we'll do that for about a couple of seconds because I know time is limited. Hospitalist, great. Hospitalist. Provider training, workforce development, PA, great. Hospitalist. Awesome. LCDC peer recovery navigator. Excellent. A recovery support peer specialist. Wonderful. And I know a lot of this might be feeling like I'm preaching to the choir because I know you all are passionate about this work, but I still feel like we can always improve with what we do. Speaking of quality improvement specialist, wonderful. And it's a great reminder also to continue doing the work that we already do. Thank you everybody for participating and letting me know what you do. All right, and so just a reminder of stigma. This is just a very simple definition from the dictionary. So the definition of stigma is a mark of shame or discredit. And so that's something that we're going to be covering today. We're not going to spend too much time going into the different types of stigma, but there are different types just for our knowledge. Example, there's interpersonal stigma, structural stigma, and self-stigma. But what we're going to focus on today is stigma in healthcare settings. And so now I want you to grab your phones. We're going to be interacting together. If you can answer this question, how many of you have witnessed or participated in stigma against someone with a substance use disorder? Hopefully, okay, good, it's working. All right, I was just hoping it was working. Okay, so far we have 9 people answering, and just what I expected, 100%. And so thank you, 11. Thank you for being honest and sharing this. It's something that definitely touches all of us and our patients in a variety of ways. Stigma obviously is really important to work on because it can cause significant barriers to treatment, and it maintains social, legal, and health inequities that exist among our patients. And so thank you for your attention here today so that we can continue the work that we're doing. And so where is stigma? Stigma is everywhere, even in our study materials. And so I'm a physician, and this article was actually very relevant to my education and what I also experienced. But this paper was published in January 2021 by 3 students from Yale who were preparing for their licensing examinations. And so while studying, they used things like the USMLE question bank, MBME question bank, practice exams, and then other study books and aids. Within this, they did notice some stigmatizing language that these study aids use. If you're not familiar with these learning aids, they use short patient cases to test a student's clinical knowledge. And so when they were using this, the students found terms like addict, abusers, alcoholic, aggressive, uncooperative, verbally abusive, all when describing people with substance use disorders. Now, this wasn't the same with people who had diabetes or, a hypertensive crisis. It was specifically for substance use disorders, which is really unfortunate. Luckily, however, these student authors recognized, that this was harmful and stigmatizing language. They understood that terms like addict and abusers are derived from the systemic criminalization of people who use drugs, and that words such as these perpetuate treating those struggling with substance use disorders as moral failures. So furthermore, in these materials, patients with substance use disorders were portrayed as irresponsible, negligent, aggressive, uncooperative, and verbally abusive. So obviously describing people in this way leads to an automatic negative stereotype. It doesn't create a sense of hope or healing for a patient or for those treating them, honestly. And so I just also want to point out and note that this occurred probably even before they participated in any patient care. And so already these students are getting inundated with stigma against substance use disorders and people who struggle with them. And so they take this, they learn this, they take it into their clinical years and into their practice. And so I was thinking too, when I was reading this article, you know, I actually noticed this kind of language within these study aids. And I'm just really grateful for these students to have actually done something about it. And so very proud of them. And I was really curious actually to see what they had gone on to do. And so Dr. Adams is now an emergency medicine resident over at Mass Gen. Dr. Fitzsousa is an emergency medicine resident over at Johns Hopkins. And Dr. Gaeta Gasola is an emergency medicine resident over at NYU. And so it's just really exciting to see the future generation of physicians really paying attention and doing this work. Here's another study. This is an article entitled "Do Words Matter?" And so this, I just want to let you know that stigma again is everywhere, and especially in the medical record. This was a study that was published in 2018 in the Journal of General Internal Medicine. The authors wanted to see what the effect of stigmatizing language was in a medical record when it came to patient care. So they studied 413 physicians in training, so med students and residents in the Department of Internal Medicine and Emergency Medicine. The students were given, the physicians in training were given 2 different vignette charts. And so one note used neutral language, which is what we're all aiming for, and the other used negative or stigmatizing language. So it was found that just by reading a note with stigmatizing language, there were more negative attitudes towards the patient and less aggressive management of the patient's pain. And so I just wanted to highlight that again, because even something as simple as reading a note can really change management of a patient's pain. And, you know, that was very concerning to see. This also made me think, like, we have to be so careful with what we document. Like, our notes follow our patients everywhere they go, and can actually dictate future treatment. So it's incredibly important for us to make sure that we're paying attention to this, changing our language, and then also for working with learners, be very careful and diligent about reading their notes and also providing feedback that can help identify and decrease stigmatizing language and attitudes. This article was written by 4 authors who performed a review of the academic literature to develop a typology of opioid-related stigma. So based on the findings, they did develop a typology of 4 main themes. We've covered them briefly earlier. So interpersonal structural stigma, stigma related to opioids for the treatment of chronic pain, self-stigma, and then what we're talking about right now is stigma in healthcare settings. So since we're focusing on healthcare settings, they actually found that 37% of the studies that they reviewed were actually, it was actually stigma enacted by healthcare professionals. So this included physicians, nurses, pharmacists. It occurred in clinical encounters, in pharmacies, hospital emergency departments. Some things that they did find was that there was widespread labeling of people with terms such as drug seeking or being difficult. Additionally, patients reported hearing negative comments from pharmacists, such as referring to methadone as garbage. If you take a look at table 4, there were some other things that they did notice within these studies. They noted the intersection of negative labels with prejudices regarding class and race. There was the perpetuation of the weak-willed addict stereotype, general suspicion of individuals just taking opioids for any reason, and then actually some providers withheld service or dropped clients due to their opioid use. Additionally, a lot of providers limited opioid prescribing due to fear of causing addiction. And so this is just another example of the way stigma influences our care. Additionally, this is another review article. They did note that there was one study that assessed whether the term substance abuser versus person having a substance use disorder held any difference in the judgments made by mental health clinicians. So again, this is a vignette study. Participants were given 2 different vignettes. One was using the term substance abuser, and the other was using the term person having a substance use disorder. So they were using person first, non-stigmatizing language. They actually found that those who were exposed to the substance abuser vignette, the stigmatizing vignette, was more likely to agree that the individual was personally responsible for their substance use and should be punished, while those exposed to the person having a substance use disorder vignette were more likely to believe that the individual should receive treatment. So this, highlighted just the importance of reframing at-risk opioid use from a moral defect and intrinsic personality trait to a chronic disorder that warrants effective and evidence-based treatment. It's just shocking that even the words that we use can really influence somebody's attitudes towards this. And so, we know stigma exists. We know we want to do something about it, but we also know that there are a lot of barriers to do so. If you take a look at your phone, it should progress to the next, interactive option. I'm curious to see what sort of barriers you face in decreasing stigma and establishing trust with patients. Right. I see people are typing. Fear of how colleagues will respond to feedback. Yeah, that's a great one. Using the word clean. Years-long established prejudices, right? This is not going to be easy to fix or quick. And then, how are colleagues going to view that intervention? Are they going to get angry? Are they going to get defensive? Providers can feel entitled and set in their ways. Some people are very resistant to change. Even the families have negative view on disorders, and the time and space to coordinate with other teams, definitely. The system versus us interacting as a person to person. Wow. See 2 more participants typing. Let's see. I'm trying large organization, difficult to provide in services. Okay. All right, thank you so much for sharing that. And those are all very valid. So somebody had mentioned time is limited, right? We have so many things to do, so many patients to see. How can we possibly be mindful of what's going on? We have a lot of patients. Also, this is hospital, right? So we don't know our patients. I mean, we might know some of them, but in general, they're all new to us. And so how do we quickly establish that trust and decrease stigma and do that work? You might also have a hesitant patient who just doesn't trust the system, doesn't trust doctors, doesn't trust nurses. Maybe they've had some negative experiences in the past related to stigma, and then also ourselves. And so I think at times we can also be a barrier to making progress. A patient's trust in healthcare professionals is paramount to their recovery. They need to be able to trust us if we expect them to follow our treatment recommendations. So what does evidence say about how healthcare professionals can increase a patient's trust in them? This was a mixed method study. They did 40 structured interviews, and then they also analyzed a nationally representative survey. They found trust-related behaviors that really improved a patient's trust in a healthcare professional. So if you take a look, we have number 1, communication, competence, and then caring. So these were the 3 main domains and behaviors that really increased trust. So patients want health professionals who treat them as individuals, who are committed to solving their health issues, that have excellent communication and do active listening and value their opinions and experiences. And then also being really competent and being able to solve those health issues in the past, and being able to provide detailed explanations that they do actually understand. So just keep all those three in mind: communication, caring, and competence. This is another study that was done. It was a literature review examining patient trust in nurses. What was interesting about this one was that they made mention of preconditions. So there were actually situations in which a patient needed to be in to allow them to trust their nurse. And so availability and accessibility, feeling emotionally and physically safe, feeling at home and valued as an individual, and feeling adequately informed, and then having, again, that respectful communication with each other. And then they noted kind of the top personal qualities that patients valued when it came to trusting a nurse, or when it came to having a good nurse-patient relationship. And so you can read all of these things, definitely all qualities that I imagine all of you contain, but some of them are, authenticity, sensitivity, humility, honesty, understanding of patients' suffering, accepting patients' cultures, lifestyles, and decisions without judgment, and then giving good advice, reassurance, and encouragement. And so just a quick summary, even though it seems a little daunting, it doesn't have to take a lot of time. You can address your patient by their name, put them at ease. So try to find ways to make them more comfortable, read their body language, reading the room, and just making sure, I think, most importantly, just showing respect and caring in a non-judgmental fashion. All right, so we've identified ways to build trust, but how can we work to decrease stigma? I would say the best place to start is ourselves. And so I want to talk about some simple steps that we can take to make this kind of change. First, we really have to acknowledge where we are on this journey, get comfortable with our own thoughts and actions. We can start decreasing judgment on our patients by decreasing judgment on ourselves. So obviously we're not perfect. We're going to make mistakes, and that's okay. What are the ways that right now we currently perpetuate stigma against people with substance use disorders? And so I know we're going to talk about a case after this, and we can maybe bring some of that into the case that's going to be discussed. Do we view substance use disorders as choices, moral failings? Or can we change that mindset and view them as a chronic illness deserving of treatment? Like, for example, when we're talking about hyperglycemia, do we call it a dirty glucose level? When we're talking about cancer, do we call it a relapse of cancer? I mean, sometimes some people do, but most commonly people say recurrence. So once we become aware of our biases, we can definitely begin working on them. Two ways of decreasing these are practicing and using perspective taking and individuating. And so perspective taking is the conscious effort to take and realize another person's perspective. So putting ourselves in their shoes. I know that this seems pretty intuitive, but it's something that we probably don't take the time to do very often. So when somebody does this, it actually has been shown to reduce implicit bias in social interactions. For example, a patient in benzo withdrawal frequently asking for more benzos. Do we label them as drug seekers? Or can we see them as a person struggling with painful anxiety, looking for help, and the only way they know how? Another method is to individuate. So individuating involves the conscious effort to focus on specific information about an individual, making it more salient in decision-making rather than that person's social category information. So it's really just making a person essentially special or unique or individual to you, other than just kind of a category. And so I did, let me go back real quick, sorry. I did want to just point out that both of these terms, their definition involved the words conscious effort. So we're actually having to be aware of this. We're having to work and practice. And hopefully with that work and practice, it can then transition into an unconscious effort that we do automatically. Oh, and then I really like this quote too. Understand and respect the tremendous power of unconscious bias. Do everything you can to become aware of and honestly face the biases that you personally might have. Both of those you know you have, and those that take some digging to recognize. The most effective measure is our willingness to confront our deepest feelings about those who are different than us. All right, so I'm thinking about changing our language. This is a helpful graphic that we can use as a beginning. We can implement these changes in our words that we say out loud, that we write down, and then also potentially in those around us. Not only can we change the language, what else can we do to decrease stigma in opioid use disorders? Werder et al., this is their work. They said healthcare workers are key to providing support for persons with OUD to combat the harmful effects of stigma. So some other things that we can do is reinforce positive aspects of a patient's choice to utilize opioid agonist treatment, provide patients with unconditional positive regard, prompt our patients to examine their own language around opioids and opioid use disorders. And so what kind of self-stigma do they have? Can we inspire them to think about it differently and talk about it differently? We can also examine our institutional policies and create systems that provide access. And then we can improve access to evidence-based practices. So all these things can really decrease stigma. And another actionable step that you can take is by participating in continuing education. So I imagine you've already been exposed to this, but I did just want to remind everybody about this resource. This is my favorite, of course, but I am biased because I was a part of this team. But several years back, the AAMC sent out a call for programming responding to the training and development needs of academic medical centers through their Opioid Education Challenge Grant Program. And so this was a fantastic team led by Rich Botner, included Dr. Moyades, Alana, myself, and we identified that combating stigma was a great area of need. The way we made things a little different with these modules is that they were interactive and that we really tried to use firsthand patient stories to personalize the illness. We did receive the grant. We created 2 open access and interactive modules that can be shared with all types of different health professionals. We don't really have time to look at this video, but it features 2 patients who have struggled with opioid use disorders and then just their experience with the system and in their recovery. And so here's a little bit more about RESET. This is Reducing Stigma Education Tools. You can just go to, just search this, resetstigma.org. They're again, interactive, free, evidence-based, and then you can also get continuing education credit by taking them. At this time, I wanted us to participate one more time in an anonymous interactive method. So just trying to commit, what is one or more things that we can do individually next week that can improve stigma or patient trust in your clinical environment? And so I'd really love for you all to share this with each other so that we can give each other ideas and just commit to doing one thing differently next week. Of course, if you have more than one thing, go for it. I love that, but just one thing. And while you all are typing, I just wanted to thank you so much for your attention and for all the important work that you're each doing in your own clinical settings. This is a journey that we are all continuously on. We might make mistakes, but that's okay. We just continue working on ourselves. And working with those around us to hopefully enact some change that can improve patient care and patient recovery. Oh, good. Okay, so I love these ideas. Share resources or document on less stigmatizing language. And Andrew, I don't know if we can, I thought we had a graphic that we could potentially send out to people. Stop using stigmatizing language and encourage my colleagues to do the same. Work with peer specialists to help support individual. Yeah, I love that. Be more compassionate. And a little bit about that too, there was this study that showed that we are more biased the more overworked and burned out we are. I know it's a huge systems issue and there's sometimes not much that we can do to improve that or decrease it, but if there's anything that can be done, just take care of yourselves as much as possible, and that in turn actually will help you take care of patients better as well. All right. Yeah, do some perspective taking and working with a challenging patient interaction. listen and be kind, even if it's not being returned. Yeah, so I mean, this is a challenging field, right? But there are ways that we can improve things, call them by their name and not disorder. So making them, person first, find things to celebrate. I love that. So kind of individuating, lean into harm reduction. Good. I love all these things. Thank you so much for committing to this. I hope that next week goes well for you and that you're able to make these changes utilizing harm reduction. Wonderful. Thank you so much. I'm sorry that was so quick, but I know we have a great, very interesting case to discuss. I just want to thank you all for your time and attention.
Thank you so much, Dr. Escamilla, for this wonderful presentation. Maybe we can take a couple of minutes to see if there are any questions from the audience before we move on to our next part of our session.
I have a quick question, and actually your Slido prompted it for me. What is a useful way to give feedback to our colleagues when we're hearing stigmatizing language? I mean, I'm sure we all have different techniques that we've used, but I'm curious to hear your perspective. And of course, we need to be on the receiving end of that sometimes too, and we all are. But what's a useful way to do that maintains relationships and all those good things?
Yeah, I'm definitely more familiar with kind of the learner setting. And so I do a good amount of supervision with medical students. And so whenever I do notice some sort of documentation or statements that they're saying, I will phrase it in, I really like, thank you for this. I really actually like to use this term instead. And this is why. And so I try to do it with no judgment because everybody, learned it from somewhere, and everybody for the most part has really good intentions. But I really just try to frame it with less pressure, no judgment, and kind of like, hey, this is the way I like to do it. Maybe this is something you might like to do also. So that's what I've done in the past. And I don't know if anybody else has some thoughts of how to maybe address it more sensitively with a colleague, which might be more challenging.
All right.
Yeah, or
Sorry, go ahead. Go ahead, Dr. Escamilla.
Maybe something else might be like operationalizing it, like, hey, like there's this movement, we're really trying to work on decreasing stigma. I wanted to share this graphic with you and see what you thought about it. So maybe even something that's not necessarily pointing or targeting something, but just first starting to share the information and then seeing where that goes.
Dr. Chen, I saw you unmute. Did you have something to comment?
Oh no, I was just unmuting for the case presentation.
Oh, okay, yes. So we will move on to the case very soon. Before that, we have, first of all, thank you so much, Dr. Escamilla. Awesome presentation and discussion. And Echo IT, if you could please bring up the announcements for me. Thank you so much. Beeville, Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Beeville, Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. Next slide. The Beeville, Texas clinic offers high-quality treatment for addiction recovery at low, no-pay or self-pay insurance, so all patients are accepted regardless of their ability to pay. Next slide. Please join us next month for Shout Echo. We have a wonderful speaker talking about reliance in healthcare. Next slide. Great news, we are launching our public safety solutions for SUD Echo on Thursday, September 8th at 11 a.m. This program is open to public safety professionals such as law enforcement officials, fire and EMS personnel, community corrections staff, and others to assist them in responding to community members with a substance use disorder. We will include the link in the chat to register. Please share with your public safety colleagues. And now we will move on to our case presentation. Dr. Chen, once Echo IT shares the case, please take it away. Thank you.
All right. Thank you so much for letting me present my case. So I'm a hospitalist in Dallas, Texas. So this is a case that I was consulted on by our orthopedic surgery colleagues. So this is a 29-year-old male, and I'm sorry. Should I talk about the questions I want to be addressed first? So I guess I want some help with seeing how we can do medication-assisted therapy for opiate withdrawal in someone with pain from a non-operative bone fracture. And then some other questions I had about this case was also how to address pain in someone who is a chronic opiate user. So kind of going to the primary reason for admission. So this was a case where a patient came in after suffering a fall when he was trying to climb a fence at his grandfather's house. So he was unable to recall the events of his injury, but he was able to say after the fall he had a laceration to his left arm that looked like it was an open fracture, having a lot of pain in his left elbow and wrist, rated 10 out of 10, constant and worse movement, and nothing made it better. Past medical history of heroin use, tobacco use, and alcohol use. He doesn't take any medications, but when he came in, they did find a biohazard bag with 2 unidentified white medication tablets. And during his hospital course, so he was given some scheduled Tylenol, some cefazolin for like periodic prophylaxis, Lovenox, gabapentin, ibuprofen scheduled 3 times a day, lidocaine patches, some Ativan, PRN, morphine, Norco, baclofen, methocarbamol, hydroxyzine, and Toradol. Social history, his brother was telling me that the patient had burned all his bridges to his family, really does not have much family support, although the social worker did mention that the mother might be helping the patient financially. The brother had recently dropped the patient off at Homeward Bound, which was one of our drug rehab programs here in Dallas, 1 week ago for drug rehab. The brother does not want the patient to go back to his grandfather's house and states that no one was planning on picking this patient up and he must be released to the community setting. And obviously the brother didn't really want much to do with the patient either. The patient had no known psychiatric history. So for his hospital course, after the fall, he was found to have a complex congenital fracture dislocation of the left elbow. So he was splintered in the ER and then admitted to our trauma surgery service. He was found to be aggressive during the hospital, to the hospital staff, for profanities and saying that he wanted to leave because of mental pain. Police ended up being called several times on him. And then medicine was consulted, I believe, on hospital day 3 to help manage his opioid use disorder. So on hospital day 1, he did have an ORIF done of the left radial neck and the left proximal ulnar fracture, and he was placed in a splint. Postoperatively, he was put on some Norco 5s and morphine 2 to 4 milligrams IV PRN, but then they found the patient to be quite somnolent and difficult to arouse. And then the following night after his surgery, the patient was yelling, cursing, demanding to go outside, specifically mentioned to staff he wanted to smoke cocaine and, quote, be with prostitutes. Then he had a female visitor come visit him at 4 a.m. in the morning. And then that morning, patient was found to have a change in mental status. He was sleepy, opened his eyes, and only groaning when his name was called. So before that, he was very awakened. So patient then admits that the female visitor had given him Subutex to take him to the hospital. No Narcan was given as patient was waking up more. Security ended up searching his room, but didn't find any other illicit substances. His visitation privileges were revoked, and then the surgery team switched his Norco and morphine to just tramadol. The following day, the patient wanted to leave for a smoke. He was found to be very irritable, didn't want anyone touching him. And then he was about to leave AMA, but then the surgeons found that he had a left inferior and superior pubic ramar fracture as well as a left anterior column and anterior column wall acetabular fracture. So he agreed to stay for more of a workup. Trauma ended up saying that both fractures were non-operable, and the plan was for him to work with a physical therapist to determine what sort of assistance he would need, specifically if he could tolerate a platform walker, or else he will be confined to a wheelchair. However, the patient was unable to cooperate with PT because of just severe pain in his left pelvis, and he was just on tramadol at this time. On hospital day 3, his CAL score was known to be 9, and patient continued to have bad pain in his left hip that prevents him from mobilizing. So he was certainly going through heroin withdrawal with nausea, anxiety, diffuse body aches. He was already on Ativan PRN. The surgery team was very reluctant to let us upgrade his pain medication, but finally we were able to convince them to at least give him some Norco. And then in the meantime, we had added on lidocaine patches. We put in scheduled Tylenol, ibuprofen. Scheduled gabapentin was already added by the surgery team. On hospital day 4, the nurse found, again, a female visitor, despite having his visitation rights revoked. And then after this visitor left, patient was again found very drowsy. They found a syringe in the room that patient reports was just for his diabetes, but certainly there was a concern that he took something. Urine drug screen ended up being positive for opiates, benzos, and cannabinoids. That night, he was noted to be paranoid and having hallucinations. The following morning, he admits to me and not to anyone else that the female friend had given him some Xanax, which he snorted in the bathroom. So he was having more muscle cramps at that time. So we ended up stopping his Ativan, giving him some clonidine and hydroxyzine. We switched his methylcarbamol to baclofen, giving his muscle cramps, and added some IV Toradol. We weren't successful at finding a sitter for the patient, and then patient became quite aggravated at this, so he decided to leave AMA. He was throwing objects around the room, removed the splint from his left arm. He was given a wheelchair to leave the hospital. Incidentally, when his friend was coming to pick him up, I ran into him on the streets, and it turns out this was actually one of our nurses. So he told me he was very familiar with this sort of behavior from the patient, and that he said he will help take care of the patient. I gave him some names of some treatment center for buprenorphine clinics that hopefully that his friend can provide to the patient on discharge. And then when I checked the PMP aware, there really wasn't anything there. So for his substance use history, he also admits to using some crack in the past. Alcohol, he really wasn't willing to volunteer how much alcohol he drank. He actually denied cannabis use to us, but his UDS was positive for cannabinoids. And then for his heroin use, he says he uses heroin and fentanyl about $40 a day since the age of 13. Previously clean for 5 years and was in the process of quitting again, and was getting Subutex from people on the streets, but then had a relapse of using more heroin this time. And then the benzos, he missed his sorting Xanax in the hospital, and the UDS was positive for benzos. So I guess in this case, my question would be, how do we manage starting medication-assisted therapies for opioid withdrawal in someone with pain from non-operative bone fractures? Because previously what we've been doing is if they have a bone fracture after they get operated on, that's when our team feels more comfortable with starting buprenorphine. And then how do we address pain in someone who is a chronic opioid user and is probably tolerant of a lot of narcotics?
Thanks so much, Dr. Chen. This is John Weems here from the Hub team. This is such a rich case. The way you've it's got so much to learn from, and then the way you frame the questions, I think, offers great learning opportunities for all of us. Maybe before going at the pain questions, Dr. Escamilla, that was such a fantastic presentation earlier. If you have a few minutes to take us through your thoughts about the role of stigma in this case and what the opportunities are to put into work some of the great tools you shared with us earlier.
Thanks, Dr. Williams. Yeah, and Dr. Chen, this is a really, I like the way you said that, Dr. Williams, rich case. And I do want to commend you all and your team in the hospital for it. Sounds like you all worked really hard to try to take care of this patient and make sure that they were safe, and that's definitely noticeable. You know, obviously I wasn't there. I don't really know kind of what happened or went down. I do know that patients can sense how we feel about them. And so I don't know if any of that did play a role. Understandably, it sounds like it was incredibly frustrating for everybody. And, you know, we're all human. We have to remember that also we're human. We're going to have our own emotions. It's just, what do we do with those emotions and how do we portray those to our patients? But, you know, some things I was thinking about was this patient maybe having like some sort of untreated mental illness that was going on? Was there untreated withdrawal? So maybe they felt like they had to self-medicate to treat some symptoms or some things. You know, I think also making it explicit to the patient that you all are have the same goal. The same goal is for him to feel better. And so let's work together to feel better. And I imagine you all did that already. And so it sounds like you all tried really hard. Sometimes also what I'll see done is like a really clear, non-judgmental contract for both sides. So what can we do to make your stay more comfortable or better, and then what can they do so that they're safe and getting better. And then just being also like really clear that everything that y'all are doing is for their best interest because you want them and you care for them, you want them to get better. And just being very clear about that. Some things that also help us in our situation, in our setting, is that we, like if I notice somebody is really struggling, sometimes I'll be very clear with them and do a medication taper of either benzos or we don't really do opioids in our setting. But when I do a med taper, that patient feels heard, they feel like they're being taken care of. And they are clear, they are aware that there is that goal to eventually come off. But right now I understand that they're struggling and they're feeling really uncomfortable. And so that's just some other things that we do to try to help these situations. But it sounds like y'all tried really hard. And I'm really curious to hear what other people have to say.
That was an awesome distillation, Dr. Escamilla. Thanks so much. And I'll open it up to the whole crew. Is anybody other thoughts, particularly around addressing stigmas or centering this patient in his care plan? Anybody on the call today?
I see a question on the chat. Does your hospital pharmacy stock Suboxone? What options for medically assisted treatment do you have?
Yeah, our hospital does stock Suboxone, we stock just buprenorphine, we stock methadone and naltrexone.
Cool. Can I ask Dr. Chin, how did was there a conversation amongst the medical team or with the medical and surgical team about the role of buprenorphine in this patient's care? I think he had talked about taking bup, non-prescribed. How did that go?
When I approached the surgeons about starting any sort of narcotics, they really did not want me to do that. I did feel that there was probably a good amount of stigmatizing language used by the primary team. And I felt when I address a patient and say, hey, we really want to get your pain under control, because I'm just reading my note here, my recommendation to try narcotics for pain management in the setting of multiple fracture that would cause pain in any person. And I try to get the surgeons to say, hey, people with bone fractures, they need better pain control. And I think by saying that to the patient, I was able to build a good amount of trust where he was able to admit to me the substance that he ended up using in the bathroom that the whole team was just unaware of previously. Yeah, so it was just difficult to do any sort of opiates when the primary team was very hesitant to let me start anything.
That's really tough. It sounded like you really reached into your doctor bag and just said, sounds like you have a lot of pain. We typically use opioids when there's a lot of pain, and that got you guys to a relationship where he felt safer divulging some of the other things going on that helped understand his clinical course. Megan Clark in the chat had a follow-up question. Did the patient ever voice that he wanted to stay sober, or how did he feel about MOUD?
He did want to say that he wanted to stay sober. He was taking Subutex, even though it wasn't prescribed, for that reason. So he definitely had a desire to do so. So he was certainly open to buprenorphine.
I have a question. So it's not a question. My thoughts on this were, I don't know how, I'm obviously not a doctor or anywhere close, but I've heard of using like ketamine, right, to do a very quick detox almost, right? And I've heard that they can it helps bring somebody down. And if that's not anything that we do here in Texas, because that was up north, then like my first question would be, would you give somebody who walked in off the streets with the same, issue medication? And would that medication be an opioid? And if it is, then why is it any different with somebody who's struggling with this? I mean, that's very often when people go into the hospitals, that's why they don't share their history, because doctors will treat them different and they don't want to be treated different. So if it's something that is medically advisable for one person, it should be the same across the board. And it's, if that person has a opioid use disorder, right? One, you're controlling how much they're getting. So it's in a very regulated space, right? So they can't just go using however much they want. Two, they're not going to be getting it on the streets, which has the possibility of, having fentanyl in it and killing them, right? So it's a cleaner supply, so to speak. And three, it's if ultimately they are going to do that, they're going to do that anyway, with or without you. So managing their pain might make them choose something else, right? So they might choose not to go back into use because they won't need to. They'll have their pain controlled. Those are my thoughts.
Thank you, Lindsay. I think that adds so much, right? Putting somebody's drug use, but then also their life within context, right? And then reinforcing their autonomy. This is a person who's going to make their own decisions. The decisions here versus the decisions on the street, which we can't control, the risk benefit clearly favors a more aggressive plan here. I love that. And let me throw it to you, Dr. Chin. Do you think you could employ a strategy like that to kind of further this conversation with the surgical colleagues?
Yeah, I think so. And sorry, the other point I wanted to, I should have mentioned was that the one thing that I kind of kicked myself for not doing earlier was checking a urine drug screen when he came into the hospital. We only checked it on the second time that he had the visitor into the hospital, and that's when we found the benzos. Because if he came in if we had drawn a UDS when he came in, and he was altered, and we found benzos at that time, that might have expanded our differentials to say, hey, maybe this patient might not only have an opioid use disorder, he might also have a benzodiazepine use disorder, and he could be going through benzo withdrawal on top of opiate withdrawal. And then putting him on both Suboxone and benzos, it gets a little bit trickier at that time. I also think that with him, despite us revoking the visitation policy, he was still able to bypass that and use drugs in the hospital that we were not able to control. I feel like by not putting him on like OUD, that kind of facilitate his desire to continue to use illicit substances in the hospital. Whereas if we had got him on something, we could have at least prevented him from doing drugs that we were not able to control in the hospital.
That's such a great insight. And some of the qualitative work that's been done has really demonstrated that. When teams have talked to patients who have chosen to leave the hospital, they often cite undertreated pain or untreated withdrawal as main drivers of their decision to leave. I think another one in this case that stuck out was like just the nicotine withdrawal, right? So if this guy's going to take smoke breaks, is there an opportunity to make sure but if he smokes every day, both a basal layer of nicotine through a patch typically, and then bolus available to him, whether it be through puffers or lozenges or gum, is and to Dr. Escamilla's point about treating other withdrawal syndromes. The benzos is a great thought, Dr. Chin. I think you're right on with that. One of the challenges is the Immunoassays for the detection of benzodiazepines are poor tests. They have poor test characteristics, and particularly their sensitivity sucks for newer benzodiazepines in particular. And so that's what one of the main challenges is. And I think it gets us back to something else you do really well in this case, which is just leveling with the patient and talking with them. Most of the novel benzos that are used on the street now, so like study drugs or dark web benzos, are undetectable on immunoassays. So like the point of care test or the first line that's often used. And most of them are also not, we don't have available LCMS or GCMS send outs for them. So it gets back to the fundamentals. I mean, just getting back in the room, trust with the patient, talking about what's going into their bodies. The altered mental status with hallucinations does raise concern for benzo withdrawal, in this case in particular. So I think that's another really important thing to consider. Something else Lindsay brought up, which I thought was a really great point, is the use of non-opioid adjuncts like ketamine, for instance. Another opportunity often with our surgical colleagues is to explore if there's nerve blockers or other regional anesthetic options. And this dude has a complicated upper extremity injury. Do you think is that an opportunity to maybe discuss with the surgical team or the anesthesia teams?
Yeah, we actually do have like a low dose ketamine protocol that we can use for pain. So I think that could have been an option that we could have pursued in this case.
And then do you have a perioperative anesthesia team that does blocks? Like especially for the hip is it's just tougher, but for the arm, is that an option?
Pain management in our hospital is pretty tricky. The physicians who do it have left our hospital, so it's a struggle to get patients to get nerve blocks. We really have to like get them to the outpatient setting, and then they bring them back into the hospital.
Gotcha. Let me open it up to the rest of the team real quick. Any other thoughts or advice about adjunctive approaches? If anybody else in a hospitalized setting has experience with ketamine in particular, or other approaches that might have helped in this case?
I see a comment from Megan. Did you want to unmute and share that? Megan, we can't hear you.
Okay, can you hear me now? Sorry about that. Dr. Chen, what a great case. And I commend you for really working through so much of this. You had a lot going on, and I've had those fights with ortho where they just don't want you to mess with anything. And that is a struggle. But I think what I've found with a lot of patients is really just seeing what they're willing to do and are they ready. And if this guy is like not ready to commit to getting into recovery, he's just going to keep having visitors coming in and shooting them up or whatever. But I thought it was interesting that he had someone come bring him Subutex. Like that was something I found really intriguing, because that's like, is he then interested in keeping his recovery going? Because he did a week in rehab before he came in, right?
Yes.
Maybe he had some time where he wanted to keep that going. And then sometimes you can use that to kind of battle the orthopods or the surgeons who are fighting you about it and be like, hey, we had a discussion and he's interested in not using opioids right now. So in the patient's best interest, you can kind of flip that on them so that they leave you alone. Mm-hmm. But I love the nerve block idea. If you have, I hate to say it, but if you have just Google and an ultrasound machine, you can kind of figure them out. We've done that a few times where we've just worked on our nerve blocks, and nerve blocks are really fun. I love it. But that is a great idea for pain management. But yeah, seeing where they're at, I think, is where you got to start. And if he's not ready, then he's just going to keep messing around and then coming to you guys and having this cycle of withdrawal and then getting something and then being somnolent. But man, what a good case. Thank you so much.
Mm-hmm.
I agree, Megan. It was a great case. Dr. Weems, in the interest of time, could you please take a minute to summarize the recommendations for Dr. Chen?
I'll echo what Megan said. This is a great case. And what's interesting is he kind of made the right decision for us, and all other things held equal, right? buprenorphine is a potent analgesic. It's a very high potency opioid, and it takes bigger systems and culture change to build an understanding amongst different teams that if we don't treat the opioid use disorder, we're not going to have a chance in hell of treating the pain. And I love how Megan took showed us taking some of Dr. Escamilla's points about individualizing, right? Say, I can't, and she shared in the chat, I can't imagine how much pain this person is in. He was in rehab a week ago, and he's already taking the gold standard treatment for the disorder. He's begging us to treat him for his opioid use disorder. And that doesn't have to go beyond today. It's just like, this is a guy today who's clearly ready to make a different decision. He stayed in the hospital for I think that's one potential application of Dr. Escamilla's points. Some other things that she brought up, address other withdrawal syndromes. And I think you did that really well. And your alliance with him allowed you to uncover some of the benzo use. Really emphasizing that we are sharing goals with our patients and we're centering them in their care, which can be tough when we're working with our particular procedural colleagues who are in the OR saving lives to try to find the space to get on the same page. And then using clear, non-judgmental communication in each of those interactions and seeing it as an opportunity to open the recovery window. Dr. Chen or Escamilla, any other thoughts from you guys?
No, I just did practice some perspective taking with this patient. I mean, if I had those same injuries, I can't imagine what kind of pain I would be in. I would be desperate and I would be doing things probably that others wouldn't agree with or, think it was in my best interest. And so, yeah, I mean, I just really did some perspective taking. He was probably in a lot of pain, especially with his history. He likely had also heightened sensitivity to pain, more so than I would. So I was just thinking about that.
Thank you so much for all your advice.
Thank you so much. This was an amazing didactic and case discussion today. Thank you all for joining today's ECHO session. As a reminder, to earn CME and CNE credits, please complete a post-session survey using the link in the chat. We look forward to seeing you at our next session on Thursday, September 15th. Have a wonderful rest of your day. Thank you.